So, my topic is All That Glitters Is Not Gold and Errors in Visual Field Interpretation. So as we all know that glaucoma is a progressive optic neuropathy with characteristic optic nerve head changes and retinal nerve fiber layer damage with visual field defects, and the intraocular pressure is actually a risk factor which may or may not be raised. The problem in our country is that glaucoma is underdiagnosed and overtreated. The reason is poor access to healthcare facilities, poverty, lack of public awareness, and lack of equipments and infrastructure. On the other hand, the over treatment is because of fear of missing glaucoma among the clinicians, the fear of losing a patient, or the fear of the patient losing sight and litigation, then starting treatment on a single intraocular pressure reading and over reliance on investigations. And improper training and lack of experience is common to both of them. So visual field tests, they are the gold standard for diagnosing glaucoma, and they play a crucial role in assessing the progression of the disease. What are the glaucomatous visual field defects? Actually, they follow the arrangement of the axons of the retinal nerve fiber layer. So there are this pointer. Okay. So as you see, the nerve fiber layer, the axons are arranged in a particular manner. This papillomacular bundle, which is straight and comes from macula to the disc, while the superior and inferior arcuate bundles, they arch above these fibers and reach the superior and inferior poles of the disc. These fibers are said to be the most vulnerable fibers for glaucoma. And on the other hand, on the nasal side, we have the radial or fan-shaped fibers. What are the perimetric dilemmas? We can have scenarios where the visual field defect is present, but there is no pathology. When the visual field defect is present, but it is not a glaucomatous pathology. And thirdly, the field defect is absent, but there is glaucoma. So, the first, the visual field defect is present, but there is no pathology. The reasons are that the test is not explained to the patient properly, incorrect data entry is done, and there is a learning curve from the patient side, very small or very large pupils. Then there are artifacts and technical issues, and the patient cannot do the test. There are certain patients who cannot do the test at all, no matter what you do and how you explain. So coming to this patient, this 67-year-old lady, she was diagnosed as glaucoma elsewhere, and she was started on one anti-glaucoma medication. But on examination, we found that the visual field showed a superior arcuate defect in the right eye, and the left eye was showing edge defect. So looking at the facial features of the patient, one can see that the hooded eyelids, they can cause these lid artifacts. And we did a lid taping and repeated the test, and now the tests are looking normal. So the pressures were normal, so we did not treat the patient, and there was no need to treat. Now, the second is the lens rim artifact, which are because of the incorrect placement of the trial lens. So the lens is either too far from where it should be placed. It is placed too far from the eye, and you get these edge defects, which are dense peripheral defects with sharp demarcation. And the reason is either a very high-powered lens or hyperopic patients, and when there are two lenses, or it can give an impression of peripheral constriction or a arcuate scotoma. Now, this is a classical example of an inattentive patient with high false negatives. The reason is that the patient, after doing the first 4 points, the patient went to sleep probably and did not complete the test properly. So that is why we get high false negatives. However, high false negatives can also be there when the patient is having an advanced disease. This is a classical example of a trigger-happy patient or over-attentive patient. You can see that the visual field on the left side is practically, there is no grayscale left, and all the points are having very abnormally high sensitivity for the age. And if you look at the total deviation plot, is looking perfectly normal, but the pattern deviation plot is showing a scotoma. We call it a pseudoscotoma, and this is because of the abnormal high sensitivity of the remaining points, that the normal points, they appear as scotomatous. So, the second type of defect is when field defect is present, but the pathology is non-glaucomatous. This is first case. This is a 75-year-old female with a normal intraocular pressure and without medication. And we found that there was a visual field defect in the left eye, including this in total inferior altitudinal field was gone with encroachment into the superior half also. So when we look at the OCT, the right eye picture is normal, but the left eye is totally anomalous. And if you look at the clinical picture, the fundus photo, the right eye disc is normal, but the left eye is showing this is optic disc coloboma. And the defect is stable in these patients mostly, and we do not need to treat them unless the pressure is going on the higher side. So similarly, this second case, here you can see there are arcuate defects in both the eyes, superior in the right eye and inferior arcuate defect in the left eye. And but if you look closely, there is the blind spot is missing here. You cannot see a proper blind spot here in both the eyes. And when we look at the other things, the disc size was very small, 1.06 and 0.94 millimeters square. There was severe thinning of the retinal nerve fiber layer. And the clinical picture, you can see there is this double ring sign, which is classical for, this is basically optic nerve hypoplasia patient. So the third case here, sorry. So this patient, she's having a pallor of the optic disc in both the eyes. In one eye, it is the superior pallor in the right eye, while in the left eye, you can see the inferior pallor. And the OCT is also showing corresponding picture. When we do the visual field test, we get this kind of pattern. So the pressures were normal, but this patient was having bilateral NAION, non-ischemic, non-arthritic ischemic optic neuropathy in both the eyes. So another case of patient with large optic disc, you can see the right eye disc is large, the cup is around 0.6:1, but the left eye disc is anomalous in shape. And here you can see that there is inferior crescent or conus kind of thing, and there is a tilt of the optic nerve, which is seen here in the OCT picture also, although the parameters are grossly normal. So when we do the visual field test, the right eye picture is okay, but the left eye you can see an enlargement of blind spot and defects on the adjacent to the blind spot and in the superior field, which is corresponding to the optic nerve anomalous area. So this is the fifth case where you can see a paracentral defect, a defect close to the fixation point in this right eye visual field. So when we do the OCT, it is showing GCC changes in the right eye, and the clinical picture of the left eye is okay, but the right eye, this patient had a history of trauma, blunt trauma, and you can notice this pallor in the right eye, and he had a subretinal fluid and followed by macular scarring in the right eye. This is the reason for this visual field defect in the paracentral area, and it is not glaucoma. Then this is a patient, 58-year-old male, who was started on dorzolamide and timolol combination in both the eyes elsewhere. The baseline IOP and visual fields were not available or not done. BCVA was 6/6 and 6/36, and he was noted as amblyopia in left eye. So when we do the visual field test, when the patient enters the examination room, actually I saw a scar on the forehead on the left side, and there was RAPD in the left eye. Disc was 0.7 and 0.4 with marked pallor, and on probing, the patient gave a history of a road traffic accident in 2007, and this was followed by a rapid loss of vision in the left eye along with a hearing loss. Neurosurgery was done, and there was a craniotomy scar on the left side. So in the visual field, you can see there is a quadrantopia. So right side superior quadrantopia with left side central scotoma actually. So this is the superior quadrant that is involved in the patient, and this left eye is the central scotoma is also present. So we stopped the anti-glaucoma medication and called the patient in 2 weeks with an MRI report. Now the neurological field defects should not be missed because they follow the vertical meridian, and this patient is another case of neurological disease when he presented to us with the field loss on the left side for 3 days only, and the patient was pseudophakic with a vision of 6/6 in both eyes. Pressures were normal, but the field tests are showing clearly that this is a homonymous hemianopia. The left sided homonymous hemianopia along with a macular sparing. So we sent the patient for a neurological assessment. The neurological part will be covered by Dr. Sumit Monga, so I'm not going in detail for these patients. So this is another example of optic nerve, non-glaucomatous optic neuropathy patient who had central scotoma in both the eyes. Then there can be overlaps also, like this patient was having tilted disc anomaly with stable visual field defects for years, but the patient is on anti-glaucoma medications, as the pressures were in 30s. On gonioscopy, we found that there was primary angle closure glaucoma also, so we continued the medication. This is the there is another masquerade, that is the lasered retina. When retina has been lasered previously, you can find arcuate scars or even peripheral scars of post panretinal photocoagulation. So, excuse me. And whenever you are dealing with a patient who is having this kind of visual field defect, when there is total loss in one eye and the other eye is grossly normal, one should carefully examine this patient and not take it as glaucoma at the first visit. So the third part is no field defect is present, but glaucoma is diagnosed. This is seen mainly in OST and pre-perimetric glaucoma, but there can be a misdiagnosis also. So do not ignore this single paracentral or nasal depressed point, which was there in this patient here in the pattern deviation. But the patient was not started on glaucoma medicine. And when the patient came back after 9 months, you see this defect has increased in size, and there is some nasal step also. So 10-2 is mandatory even for a single depressed point in the central area. So to summarize, a meticulous workup and documentation is needed. Reliable fields and reproducible visual field effects should be there. And unilateral advanced field loss should always ring a bell. And central vision is spared in glaucoma till late stages. If the patient has lost vision, so especially in one eye, one should deal with the patient with caution. Then multiple diseases can coexist and produce visual field defects, and there are overlaps and gray zones. Then one can make use of the diurnal variation or neuroimaging tests wherever they are needed. Thank you very much.
Thank you, Dr. Swati. Any questions to Dr. Swati? I think visual field is again very important, because any field defect is not a glaucoma. So many times happen that you are screening for glaucoma, and if the visual field defect comes, then the tendency is to label that patient as glaucoma. But I think Dr. Swati has very nicely told there are many other situations which can produce visual field defect, which can be confused with glaucoma patients. So it's always better to look at the total picture. So look at the visual field defect, whether this conforms to glaucoma or does it conform to any other known entity. Is a central scotoma, it's a altitudinal defect, or it's a vertically like hemianopy kind of a pattern. So that actually gives you a some idea whether this is glaucomatous or not. And also other diseases you have to keep in mind that a laser has been done, or there's a CRV or VRVO particularly, they can produce a pattern which is similar to glaucoma. So I think again you have to go back to the patient, look at the fundus and see if there's any of those conditions exist before you label that patient as glaucoma or the visual field defect as glaucomatous. Thank you,